Thanks for joining and welcome to a new webinar on the Mental Health Innovation Network. I'm a technical officer at the WHO Department of Mental Health and Substance Abuse in Geneva. Our today is the second of the Ask the Policy Expert webinar series. The Policy Expert webinar series will focus on country-level implementation of one of the Mental Health Action Plan objectives. As many of you already knows, WHO Comprehensive Mental Health Action Plan 2013-2020 was adopted by the 66th World Health Assembly. Through the series on MHIN, we aim to learn more about the approaches used by policymakers to implement mental health programs, and policymakers are aiming to achieve the action plan targets. This is Objective 2, to progressive, integrated, and responsive mental health and social care services in community-based settings, and a target of increasing access of people with severe mental disorders to services by the year 2020. Our day is Ethiopia, and we have our distinguished speaker, Dr. Tedla Giorgis, at the Ministry of Health in Ethiopia, who will discuss with us the ongoing reform of mental health services in Ethiopia to develop affordable, accessible, and acceptable mental health services for all. In case you have any questions to Dr. Tedla, please send to me using the chat function. To Dr. Tedla's presentation, you can click on the tab on the top of the screen with Dr. Tedla's name. It is yours. Thank you.
Thank you very much, Fahmi. And so my presentation today is going to be a little bit of history and then how we went about developing the national mental health strategy, forming policy for mental health in Ethiopia, and to be able to scale up mental health services using the WHO's MHGAP. So that said, the issue of mental health, from the perspective, this is around 4 years ago, on the time when we mental health strategy, was the policymakers understood that Ethiopia was on an accelerated economic and social development path, and they're developing 10% growth annually. So there's a rapid increase in economic development. What it means is we needed that physically and mentally healthy population in order to maintain and sustain the end of this economic and social development. So the way we phrased it was simply that mental health services is a good thing to do for services for, but it also contributes to Ethiopia's economic development. So I guess from a policy perspective, it's very, very important to look at mental health, but its contribution to a healthy society, to provision of, to how it's going to provide to achieving the economic development goals of the country. That the powers to be and the policymakers, decision makers understand that it does contribute to economic development. So, looking back 4 years ago or 5 years ago, Ethiopia had a very, very, minimal infrastructure, and human resources to provide mental health services. Like we had 326 beds, we had 36 psychiatrists. Then now I think we've got around 70. We're talking about for 95 million people. Psychiatric services, we had 461, maybe a little bit more now. A psychologist engaged in mental health, 14. So when you look at the whole range of mental health practitioners and the population, there's disparity. So this gives you an idea. And then when you look at, in terms of, prevalence of mental illness in Ethiopia, similar to any other country, it's just the same prevalence. In terms of common mental health disorders as a whole, 12% to 17%, schizophrenia, 0.7, and so on and so forth. So Ethiopia is like any other country, the prevalence of mental illness in Ethiopia is very similar to other country. When we started, we did a SWOT analysis. Of course, strength, there was weaknesses, opportunities, and threats, as a SWOT analysis. At that time, there was expansion of training programs, in mental, for example, we're starting to provide a bachelor's level psychiatric nursing programs. Even now, we have a master's level 3 programs for prescribers, appropriate of allocated budgets. That's the strength, meaning that the ministry was allocating a little bit more budget. And then they were expanding centers for the treatment of the mentally ill. So there was some movement. This is 4 years ago. So of course, in terms of the amount of budget being allocated, low resource, the budgets used by hospitals, the lack of parity, inequality of care, if you want to call that, limited resource for non-medication alternatives, in other words, long-term rehabilitation and psychological treatment, organized referral system, from the health center, from the health post to the health center to the hospital, and difficulties of staff retention in terms of career path. Staff, they may be trained in subject nursing, but if they don't see future, there was high attrition rate. There was a lot of, there was a good political commitment. In our case, we're lucky to have a minister not only committed to the mental health movement, but he himself was head of mental health, before he became minister, state minister and president general, so that was a good opportunity. There was an improvement in infrastructure, expanding of health centers and also health posts, for example, in Ethiopia. In 10 years, we had gone in terms of health centers from 100 to 3,600, and then health posts going up to 16,647 health posts, which is the smallest denomination of an infrastructure where health services were being provided. So there was a lot of devolving of power and decentralization going on at that time. The threat was, how budgets were going to allocate, low budget, lack of alternative services, stigma, and, poor implementation or use of available research evidence, and of course, lack of medications and so forth and so forth. So this is the whole scene around 4 or 5 years ago. That's when we started to adapt the image gap project. So, let's see from the slide here. So, there are these driving forces and restraining forces in terms of force field analysis. One is there was a poor provision of coordinated services to the patients that are mentally ill to ensure comprehensive of care, and at that time we didn't have a national mental health strategy that was developed, that we developed at that time. Provision of mental health services relies on monitoring, tracking of patients and linking them into a very fragmented system. So that was this driving force, which is the capacity of the existing force, resources, political commitment. There was this political commitment, from the Minister of Health, the leadership, and the regions, and so forth. So in terms of the training forces, in the country, mental health was a new concept. Where the hospitals really were not pretty, they are pretty, but at the same time, it was not in the part of the high priority. And health networks in Ethiopia are highly fragmented and overwhelmed. Introducing a new role could lead to competition, duplication, or inability to perform. And have that mental health strategy. So there was no legitimacy to push it down to the regions, because we had to engage the regions, for the scaling up of mental health services by developing the national mental health strategy, and for the region to understand this is a priority for the country. So that said, let me just give you this health services delivery infrastructure in Ethiopia. You've got the national level, where you see the green, and the regional level, where you have first, you've got the Ministry of Health, and then you've got the regional health bureaus, in yellow that you see, and the red, you have centers and health posts, and then, of course, in the bottom of the pyramid, you've got the parent. So you've got the ministry up there developing the policy and so forth, and then health bureaus. There are 9 regions, actually, and health networks. So there are around 3,600 something health centers, and there are 16,647 health posts, like I said before. So our aim was to provide services at the health center level, leveraging the already existing structure, using the image gap formula to provide training and to make sure that the health centers are, have adequate medications, supervision as well. So what we did was, we used what we call the 7S model to kind of conceptualize and to identify some of the issues that we'll be facing to scale up mental health services. And then the first was a superordinate goal. The vision was integrate mental health into the existing public health care system. In other words, the strategy that we developed advocated training those on mental health issues using the image gap program, and then to make sure that they are provided, the right supervision, the right encouragement to provide services at the different health centers. So relying on bringing in, psychiatric nurses, psychiatrists, and so forth. As I told you earlier, for the foreseeable future, they're not going to be enough. So our superordinate goal was to leverage the already existing health structure, is the health center level, and then for patients, for difficult to treat patients, or patients who are not responding to medication or specialized type of consultation, they are pushed higher to the hospital level. But our main initiative was to integrate mental health in health centers. So it was, our asking, what should be the goal? What should be the priorities and scope of the integration of the mental health stakeholder? You're talking about health center, the patient, the family, and so forth. So we had to have a very clear understanding in terms of our strategy. So this, and oriented our thinking on the integration. And the next one is, since we're going to leverage in the already existing system, we asked ourselves, what are the necessary processes, procedures to make the integration of mental health services into the PHC operational, for example, in terms of making sure that the adequate medication and supervision, referral systems up and down from the health center to the hospital up, and then for referrals from the health post up to the health center and so forth. So we're trying to understand the processes and the procedure to make the integration work. We had to understand the structure. But how should mental health services be structured into task roles? What would be the responsibility of the health officers, the nurses? For example, at the health center level, there are specialized HIV clinics. How can we grade it and leverage the already existing system for the provision of ART? And our strategy is to totally integrate it and leverage to the already service delivery, whether it's taking place with tuberculosis, HIV/AIDS, malaria, whatever, and develop a specialized silo exclusively for mental health. And that, and we did that, at the hospital level because there was a specialized clinics for mental health, but not at the health center level. And the other thing that we asked ourselves was, what type of skills, experiences, knowledge and attitudes are required to make the integration and delivery of mental health services operational. What should be the focus, in terms of diagnosis, follow-up, and social rehabilitation. What are the knowledge of, in this case, the MH-GAP training methods and approach was extremely helpful to us. And we have to ask ourselves, okay, what type of staffing and what type of resource do we need? If we are scaling up, what type of medications, do we to make sure that there's a continuity in? So we have to do some drug quantification as we're scaling up to make sure that the medications are available, to make sure human resources are trained, the supervision is conducted in a timely manner. Because our experience from MH-GAP is, yes, it's a good training package and everything, but it has to be supported or supplemented with very, very strong, supervision, because training is short, so it has to be reinforced, and that's what we did by providing support to the regional health bureaus. What management style is needed for integrating mental health? Because, we don't want to come in and say, this is what you're going to do. How are we going to integrate it? Because the system already exists at the health center level. But, for example, in the HIV, they use multidisciplinary teams. So how are we going to integrate mental health into that? What type of style of supervision, management style should be implemented at the health center level? So this is kind of a conceptual scheme that we use in order to understand how we're going to be able to integrate and leverage the already existing system as part of scaling up of mental health services. I don't know this clapping, but so far, just this last year alone, to integrate mental health into 160 health centers. So quite a rapid increase in what I've done, and I guess this is my presentation.
Thank you very much, Dr. Tedla, for the excellent presentation. Really very, very impressive to see the achievements and scale-up of mental health services in Ethiopia, and also the scale-up which is achieved in such a very, very limited time. So thank you for this excellent presentation. I have a question from my colleague Dan Chisholm. Dan, would you like to share your question, please?
Good morning, Dr. Tedla.
How are you?
Very well, thank you very much for the excellent presentation. I actually had two questions. The first was how the 7S model been published so that others can learn from this. It seems a very well thought through sort of criteria or domains which other people could follow to structure a process of reform and development. The question was more around the kind of what I call the alignment of the stars. That you have in Ethiopia you have strong, impressive economic growth as well as the political commitment, and those are critical factors which have helped sort of really push things forward. And I suppose my question is, how do you think things would have turned out if the level of economic growth had been low or non-existent? Would that have made a fundamental difference to the planning strategy process? And I suppose likewise, how critical do you think it has been to have a Minister of Health in office who has an in-depth knowledge and understanding of mental health and the needs of the population?
In terms of the 7S model, no, it has not been published, but it's an interesting proposition, which we'll consider public. Because what it did for us, give us kind of a comprehensive view in terms of to shape our thinking, to shape in terms of the planning and the implementation. So we had a very holistic view of what it took for standpoint to shape, and to guide our critical thinking. And, how I used that was, I used that presentation to a lot of policymakers, because that's the way they think. Policymakers think of the larger view in terms of how the whole thing is going to fit. They just can't afford, just to think in terms of mental health, malaria, and so forth. We had to come. When we presented to the regional health bureau chiefs and so forth, we had to make sure not only to talk about mental health, but to show them that it's just not one more thing that their staff have to do. This is to increase the quality of services that they are going to be providing. This is just going to be added value. So on the 7S model, when you're dealing with the policymakers, a good way of showing them holistically only how it's going to fit a whole thing, but it's just not an external thing, one more thing that they have to do. So it hasn't been published, but it's something that I guess I'll have to think about, and I can talk to you about that. The second is, what would have happened, if all the ingredients in terms of Ethiopia's accelerated growth, if that didn't happen, then I really don't want to think about that. I'm glad it happened, and I'm glad we have a minister who was a former head of mental health and so forth. But kind of speculating, of course, it would have been harder. But although it would have been harder, I think I was involved both in the U.S. and Ethiopia on mental health issues for 3 decades. To me, the issue mental health is that has come. There is a lot of sensitivity in terms of the importance of mental health issues. You go anywhere in Africa, it doesn't matter the rate of growth, but in terms of the accelerated pace in life, education level increasing, and so forth and so forth. Really, to me, this is the right time for mental health. And as you know, April 13th, there's going to be a big World Bank mental and WHO meeting mental health, and this is heard of. I think that's going to be taking place in Washington, where our minister is going to be presenting. So yes, it would have been harder if that was not the case, but at the same time, I do believe the time for mental health is a lot of, understanding, appreciation for the issue of mental health, and but like you said, like I've always said, the whole issue of mental health, Ethiopia, and the stars had lined up, and I'm glad to be here, to be a part of this movement.
Thank you, Dr. Tedla. I have another question about the rules for non-health sector groups. For example, social sector services, traditional healers, and law enforcement agencies. Can you provide us with examples for the rules within this program?
We made sure in our national mental health strategy that we're very, very clear that in terms of the importance of making sure the faith healers, the faith-based organizations, as being a very, very important ingredient to our scaling up services. Because let's face it, in Ethiopia, a lot of those people initially, with mental health issues, go to the faith healers, go to the Orthodox Church, go to the to mosques and so forth. And then, we may be at last resort. So, National Mental Health Strategy, we have made sure to stress they are mutually exclusive. We have to, make sure that everybody is working together. So now we've got some projects whereby we have the leaders from the faith institutions, from the Coptic Church, from the mosques and others to come and talk about mental health issues. For example, every year we have a National Mental Health Symposium that takes place in Ethiopia, and the first speakers are from the different churches coming and then giving it their blessing or whatever. So we're very, very much sensitive to the roles and of what the faith-based institutions have to contribute. The other one is the role of, for example, the other health sectors. Ministry of Education, Ministry of Justice, and so forth. It's really not easy to work across the countries. For example, if we're really going to invest, to me, we need to invest when children are young, in the schools, where the parents are accessible, where the children are amenable, where the cases have not become chronic, and so forth. And we have a long ways to go in that. So I see that as a very, very important ingredient, to make sure the other mental health sectors are involved in this. The other one is, for example, in terms of forensic issues, we have started a good process to ensure services are provided in the prison system, and the competency and productivity exams for forensic cases are taking place at some level for those who are appearing in courts or so forth. So mental health is just not for the issue for the Ministry of Health. We do it making sure we get partnership, engagement, and a buy-in the other social sectors as well.
Great to hear that a multi-sectoral approach is being applied during the scale up process of the mental health services. I have another question about sustainability. How funding for this scale up process?
That's a good question. For example, initially when we started, the MH gap funding was very limited. I think we may have scaled up with us, 25, around 20 health centers. Like I said, 160 health centers that we scaled up last year. That was only funded. In other words, what we have been able to do successfully is to institutionalize the fund mechanism. In other words, now it's part of a line item budget in Ethiopia's, budgetary allocation within the Ministry of Health. Those for the scaling up, 60 health centers, for example, we did a drug quantification and we found that we needed $500,000 for part of the drug quantification for procuring tropic medication, and we're able to successfully do that. We just procure the medication, the medications are arrived, and so forth. Sustainability is very, very important, and you just cannot rely on foreign funding. At least what MHGAP did for us was give us an incentive to start the program, highlight the importance of the issue. At least it became a primer, a prompter to what followed. And then one I'm happy to report in Ethiopia is in terms of mental health budget. Allocation budget is a line item budget and it's institutionalized. Just in drug procurement, we're talking about training, you're talking about supervision, risk prevention. And it was all done with low funding.
Excellent. Thank you, Dr. Tedla. This is very, very clear. I have another question from my colleague, Agnes Becker. Do you have any problems with the uptake of services? If so, how did you address these problems?
Well, there's several issues that we still deal with. For example, one thing we realized was we were just scaling up too fast. Really gun-ho, let's do it, and so forth. So you see, as you're scaling up, sure, you have to get the drugs, available there. You have to make sure that you provide, supervision at the right, at the right dose, and then also remember to make sure there is a buy-in and ownership. Isn't done by Ministry of Health staff. What we did was we provided technical assistance to the regional health bureaus. We provided the regional health bureaus monies for training and supervision, but we provided them, with the drugs. So remember, a bar has been developed, so we have to make sure to work with the regional health bureaus so that the training was done in a timely manner. The provision of supervision was done also in a timely manner and so forth. But also, what we did was we provided the monies to the regional health bureaus for training, and we provided monies for supervision to the universities. There's psychiatry and mental, like there are some master's programs. So we diversified where training was taking place and then supplemented. So and also providing that money, to the universities to provide supervision. What it did was, it incentivized the psychiatrists, the mental health practitioners, and so forth to go out and then, to do supervision. So there was a lot of complexity. So we had to go to the regions, for supervision, from the ministry. So it was not easy. It's still not easy. But we heard that it was not done it was not done from top down, that the ministry took responsibility to do everything. We empowered the regional health bureaus to take over. We provided them with support. They also provide their own money because that's the only way you can be able to make it sustainable. And then one thing we realized was, since we're really scaling up fast, at the same time, we realized that we have to also create demand. As you know, it's useless. So now what we're doing is we are going to be training the health extension workers, for referral, for detection of symptoms, and for referrals, and using the media and other means, the National Mental Health Symposium. But you've got to make sure for people to know that the services are there, they can get services, this is how you can go about accessing the services and so forth. So while you're scaling up, you have to also be privy to also create that demand.
Thank you very much, Dr. Tedla. So of achievements on objective 1 of developing a national mental health strategy and objective 2 of service improvement and service scaling up. Can you also tell us about achievements on objectives 3 and 4 of the Global Mental Health Action Plan? Objective 3 on developing prevention and promotion programs, and objective 4 of developing information system and research. Can you give us some examples on achievements on these 2 objectives?
Well, in terms of prevention, our focus was first in terms of dealing with the severely and consistently mentally ill patients. So intervention, thinking, how to use the media to understand in terms of mental illness, and then also, our viewers, we need to get in the, school systems and to the work environment and so forth. We have a long ways to go. And promotion, we're doing fine in terms of promotion. There was a National Mental Health Symposium annually. using the media. There are some radio programs that are going on, TV programs. So slowly but surely. And the other was you're talking about research on what was the one?
And information systems.
Well, in systems you're talking about the HMIs. The HMIs, again, I mean, the health management information system, for us, it has always, it has been a struggle to make sure that all the indicators that we want to see as for and so forth are integrated as part of the reporting system. And we're negotiating, with the planners, which indicators, which data should be collected. That's been easy. That's still work in progress. So research, at least in Ethiopia, there's some really good research going on, with crime, with emerald, and then we've got some being funded by the Stanley Foundation, by NIMH, and so forth. So, in terms of research, in Ethiopia, in fact, it's one of the prominent African countries with a lot of obligations in terms of research, both in terms of service provision and as well as, clinical issues. There's some good, decent research going on, but a long ways to go in terms of the HMIS system.
Very good, Dr. Tedla. I have a question from my colleague, Marika van Richteren-Altina. Maria, you can go ahead, please.
Thank you, Tedla, for the great presentation. My question is just in relation to the early stage of the scaling up, and what were some of the barriers you faced in those early stages, and particularly what advice would you give to countries that are in those early stages and have barriers around limited technical expertise on the ground, despite the passion and the commitment that's coming from the ministry and the understanding that there is a need to develop services?
You see, right outset, we understood that we're going to be scaling up in the regions and the regional health bureaus. If there's one thing that I advise people is to make sure you make it times as possible and then go in person to the regional health bureaus and work with them in person. You do not do it using remote control. You'll be surprised initially. It's not sending them the national mental health strategy. It's not emailing them the strategy. It's actually going there and then talking to them, kind of nudging them, understanding, who is doing what, developing champions from within and so forth. So that they're resistant or, they're not taking it as a priority, but have a lot on their plate. They've got malaria, they've got HIV/AIDS, they've got a host of things. This is one more thing to do. It's not that they don't want to do it, but at the same time, by going there, by negotiating with them, and by providing them with support, and actually sending some of our staff from the ministry, to go to some of the health centers, develop champions and so forth. So, yes, it was hard. But, for those who are in the ministry, what I really suggest is you've got to go to the regions and make sure to nudge them, to show them, to handhold whatever it takes. So initially, when you go, at least, we had that legitimacy because even when we developed the National Mental Health Strategy, we made sure all regional health bureaus, everybody, and we had made sure that their fingerprints were on the National Mental Health Strategy. So we're aware of it. But being aware and actually implementing it is a whole different ballgame. Therefore, my advice is really, if you believe this is going to, you need a buy-in or engagement. You have to go to the regions and work with them.
Mm-hmm. Thank you.
Okay, one last question is actually about the Mental Health Innovation Network. In your opinion, how do you think the Mental Health Innovation Network can help policymakers in achieving their objectives?
Well, innovation is good, but as a policymaker, trust me, we really don't go too much on the look at what are the innovations. We're too busy doing so many things. My advice is, what it means innovation is, you can learn from this. These are new things that are coming up that you can and should consider. I mean, that's what it's doing, Also, it's sharing of platform for practitioners and researchers to say, look, we have done this works, this doesn't work, and so forth. But I think it would be full, even in a way that's targeted to policymakers to come in a specific email or something in a printed format, because sometimes, it's so much, we don't even look at, half of things that come to us, we just click, and so forth. But so for me, the question is, whether the Innovation Network is a good idea or not. Of course, it's an excellent idea, but how does it get the eye of the policymaker? How do you make it really on top of huge, I'm looking at my desk right now, full of, paperwork, there. On top, at least, for me to look at it. So I think it's relevant. I think it's a good idea, but how do you really make sure that the policymakers are really reading it, and then it's on top of the pile on their desk?
Okay, thank you, Dr. Tedla, for the good advice. And as we are approaching the end of our webinar today, I would like to please ask you if you have key messages to policymakers with learned lessons from your experience in Ethiopia.
Some advocates for mental health and so forth talk about exclusively about mental health to policymakers, policy shapers and so forth. If we really do to understand how ministries work, how policymakers make decisions, how do they go about prioritizing issues? How do they go about allocating budgets? How does the system work? The ministries, who does the drug quantification? How are monies allocated for procurement? What's the process for the HMIs? How are decisions made in terms of what indicators are in and what indicators are out? So we have to be part and parcel of the system, understand how the system works, so that we can be able to influence it. So, my advice to researchers is, to approach your ministries and then how you can make a relevant contribution. Not only in terms of mental health. I mean, there's a lot you can contribute to the NCDs where, where mental health is subsumed under. So let's not simply talk about mental health in itself. Let's talk about mental health as part of the economic development. Let's talk about mental health as part of the NCDs. Let's talk about mental health as part of AIDS. Let's be holistic in our approach and understand how ministries will work, ministries of health work, so that we can influence, the making. My advice.
Thank you, Tedla. We appreciate how busy your schedule is, and we're really grateful for the time you provided us on MHIN, and we would like really to thank you for an excellent presentation today and the insightful tips and know-hows you provided on MHIN for scaling up mental health services. Thank you, Dr. Tedla, again.
Welcome. Thank you, everybody. Have a blessed day.
Thank you.